I'd like to begin by acknowledging the traditional owners of the lands on which we are meeting today, and to pay respects to elders past, present and emerging, and to recognise that many of the issues we will be talking about today have particular implications for our First Nations people. If you wouldn't mind making sure that you can put questions into the Q&A function on your screen tonight. It's fantastic to have you here for our next cancer conversation discussing virtual care. I'm going to do some brief introductions and then we're going to go straight into a panel situation. Tonight's meeting will be recorded and will be available on the Cancer Institute website. If you do need a certificate of attendance for professional development purposes, there's an email address in the chat function, so please send us an email. And following the webinar, there will be a short evaluation that will be emailed to you. So please help us enhance this cancer conversation and complete it. So the four panellists that we have here tonight are Dr. Mathew George, Dr. Israfil Baluwala, Dr. Craig Underhill and Jennifer Hamilton. So we're going to begin tonight with a presentation from Dr. George. Dr. George is a medical oncologist based in Tamworth. He's an associate professor at multiple Australian and overseas tertiary institutes and has a special interest in supporting and treating patients across geographically diverse areas and for those who are financially and socially disadvantaged. Dr. George was the first applicant for a Cancer Institute telehealth program and has had about 12 years experience in providing virtual care. So a real pioneer for New South Wales. So welcome, Mathew, and please, Tia, I think, start the presentation.
Thank you. Can you hear me?
Yeah, all good.
Okay, thank you. So my presentation is, the topic is the connecting regional and remote areas. So I've been working in Tamworth for the last 13 years. I've been working as a medical oncologist, and I started the Tamworth clinics or Tamworth Medical Oncology Clinic in 2009. At that time, that was an outreach clinic to Mater Hospital and Prince of Wales Hospital of Sydney. And subsequently, 2009 onwards, it became an independent center. 2010 or 2011, it became a regional cancer center. And from there, we started the outreach clinics to Moree since 2009. And now the outreach clinic as Moree has gone into some smaller areas in the town like Narrabri and other areas. So it's a great privilege for me to explain my experience in Tamworth. Next slide. So this is the geographical area where we are covering as a team. So we have Dr. Baluwala also here, he's a hematologist, and Jenny is here from Moree. So we can see the Tamworth in the Peel cluster, and we started the first outreach clinic from Tamworth to Moree in 2009, and it has grown exponentially, that Moree clinic. And when I say Moree clinic, that clinic is mainly it's clinic catering to the Indigenous community. And we started the clinic, I would say in 2009, there was 9 patients in the outreach clinic. Now we are nearly seeing nearly around 150, 200 patients per month. And then that many number of patients in the chemotherapy. And then from that clinic, we could go into the have a good influence among the Indigenous community. And now it is one of the biggest chemo unit in the rural areas, catering to the indigenous community. And I'm very proud that our team has done a great job in doing so. And Tamworth, you can see here, Tamworth to the Moree, and Moree to places. Now that Moree is catering to Narrabri, which is another small country town. And from Moree, it is going into smaller areas, Viva, Albury-Wodonga, all those places we are catering at the moment. And not only that, Tamworth also doing telehealth clinic to partly to Aranda clinic. Next slide. So this is a few statements which I would like to mention. Approximately 1/3 of Australians with cancer live in regional rural areas of the country. They have a lower rate of survival than those in the city because of less availability of diagnostic and treatment services and later diagnosis and lower socioeconomic status. As the remoteness of hospital increases, treatment and support are increasingly provided by less specialized staff. So this is what we try to change in our experience, that people who are living in a very remote area, I have hundreds of cases I can explain how this type of outreach clinics and telehealth have changed the lives of hundreds and thousands of people who could get not only specialized care, subspecialty care at their doorstep. Next slide. So rural oncology services offer patients access to an oncologist in that community. It combines the research with the clinical work. So we could do so many of the research activities in our remote communities, apart from the clinical work. And I could easily say that it puts together a whole team of oncologists, general practitioners, nursing and support staff. The care in the rural area or remote area is impossible without the support of the general practitioners and nursing staff and support staff. And I think more Jenny will explain to you in detail how much of support that we get in this rural area by the general practitioners and the nursing staff, because every day we get lots of phone calls from the general practitioners about the patient's need. And so we could fit into the clinic and we fit into the video telelinks or video conferencing so that there is no delay in the treatment, there is no delay in the initiation of the treatment. So I would say it is a teamwork by the specialists and the nursing staff and the general practitioner, there is no doubt. Next slide. So I would like to comment on the technology, which for the last 13 years, I've been doing the teleconferencing. It started with the hospital video links, and then we went to Swapio, then we went to Zoom, then to Skype. And now we are in virtual care. And we have gone through each and different platforms from 2009 onwards. I could see how the technology has advanced, and now we are in a better position in terms of virtual care. And we could see the people within a matter of few minutes. And if I'm sitting in Tamworth and I wanted to see a patient in Moree, the nurse in charge of the Moree will give me a call, and just a matter of 1 minute, I click the button and the patient is sitting there. And the nurse may not be there in the clinic room, maybe in some other room. So some other patient, their family members will be at some other place, they can add. So it's a really, I don't know how can I explain, it has a huge difference in the technology in terms of teleconferencing for the last 13 years. It allows for a shared care of the patient with the general practitioner during follow-up and results in a reduction in hospital visits. I usually have many times the general practitioners will be there during the consultation, but they are quite busy. But some of them are quite happy to be joined in some of the consultations when the patients are very sick in the ward, or when the patients are in the very rural areas where even the GPs are not available. I have patients in a country town called Viva. There is no many doctors in that country, in that hospital. Only nurses are there. So there we could help the patients by providing support, and the patients and the family will be sitting in the bedside, and the teleconference that has, I think that is the greatest experience that I have ever have experienced in my life, because how the people's life have been changed in the last couple of years. This includes community-oriented projects, and we could introduce so many projects in Moree, and especially in the indigenous community cancer, thanks to the Cancer Institute for providing such support. So this has revolutionized these people in this area. Next slide. So this is a publication which we did it in 2014, that is before the COVID time. So it's a rural oncology, overcoming the tyranny of distance of improved cancer care. This published in Journal of Oncology Practice in 2014, which clearly shows the importance of care in a rural and remote area with the help of telelink and teleconferencing. Next slide. So these are the benefits which I have come across in my practice for the last 13 years. It increases the timely access to appropriate interventions, timely access to care, reduces the burden of waiting, reduces the burden of travel, reduces the burden of carers, reduces the financial barriers, and the most important thing is reducing inequities in access to healthcare, which I find is the most important thing. People in Viva, people in Varialda, people in Mangandai, that is 100 kilometers away from Moree. So they all can get the best treatment in this country town, in this regional area. And I would say this technology and these methods have changed the people's life. And they don't have to come to see a specialist for a face-to-face consultation for 5 minutes or 6 minutes. And this will help them. And it is more of a patient-centered approach. I would say when I do the teleconferencing, I'm looking at the patient and I am not distracted anywhere. And that's really a good thing. Nobody is calling me, nobody's entering into my room, it is closed. And then I'm looking at the patient completely most of the time. And not only that, and this approach and many other people, nurses, allied staff, social worker, they are also being part of this approach, and then GPs are. So it's quite an amazing experience. Next slide, please. So clinical consideration, and what I have found is in my practice, I told you that the different platforms we have, but the documentation is something which is very important in this practice, because when you see the patient, you document the clinical notes, then we should have a patient consent. And most important thing is, it is the responsibility of the physician who is doing the telehealth, whether we should be confident that we should be able to abort the consultation when there's a need, because there are times where the patient, we can't do anything on the virtual care. The patient should go to emergency department or see other doctor, and that's it. We should not waste time. So the clinical consideration, documentation, patient consent, it's clearly up to us. And I think for the last 13 years, my team has understood that which are the patient to be put on the telehealth, which are the patient to be seen by the specialist, which are the patient not to be seen, because it is extremely difficult to have a teleconsultation, especially when you're having to talk about breaking the bad news, social issues, and it is extremely difficult. And sometimes then you may have to do a lot of support in the other end. Next slide. So this is my Tamworth experience. So we do the fortnightly telehealth with Moree and weekly telehealth with an Aranda clinic, which we started very recently. And we do the pre-chemo assessment for almost every patients on request from the nurse on the other side. Not all the patients. If there's a request, and it will be done on the spot. That is only because this is mainly on the new technology, the virtual care that is available in our system. And family meeting for patients in the rural community hospital. I think I have lots of experience of how we have conducted family meeting when the patients are really in not only a regional or a remote area where not even a specialist or not even a general practitioner there to look after. So we could utilize these telehealth methods and also the nursing staff there to support them. I really, in a month, on an average 80 to 90 patients are seen through telehealth alone. And I think it is the number going up now. My virtual care is an excellent platform for the moment, and with a good IT support. I don't have anything negative to say about that care. Nurse support, that is the backbone of this telehealth. That is the backbone. If you don't have a nurse support, and I think that the telehealth is going to collapse. My experience with Moree team, with the team and Jenny and the team, and all other people in Narrabri and the Tamworth, and an excellent nursing support for the patient. They are sitting with the patient, and when I talk to the patient, they try to explain to the patient it's something which I have not understood. If a nurse is not there, the telehealth communication is not going to be successful. And then lastly, the social worker, which I great, and I really enjoy the presence of social worker in some of the telehealth meeting, because I think that is quite important when we deal with the cancer patients, when they are extremely anxious and emotionally upset. Next slide. Moree experience, which I explained in the first slide. This is my experience since 2009, December. This is nearly 13 years now. So telehealth in oncology in this remote area, this is actually 300 kilometers away from Tamworth, or in other words, around, I would say, 700 kilometers from Sydney. Telehealth is all the time, patients are followed by face-to-face clinic. So that is an important thing, because it is a hybrid clinic. It's not all the time a telehealth alone. So we make sure that patients who are seen in the telehealth are seen next time in the face-to-face clinic. And telehealth, it is used for the family meeting, which I mentioned. Nurses and social workers are there to support for the telehealth. And Moree Clinic is reaching out to more remote places to help patients and supporting other chemo units like Narrabri. And what I understand from the many years of my experience is that it is well accepted. People are enjoying this service, and more people are happy to attend a telehealth clinic. And general practitioners and nurses and social workers are the backbones of these clinics. Next slide. This is the last slide, moving forward. So what we have done at the moment is patients are in the public, either in the regional hospital area, district hospitals, or remote hospitals. So we try to do these things through the hospital setting, where the patients can come and then coordinate. But I would say the time has come for accessibility from home, from their own phone, and we need more nursing staff to help this thing, because we need people in the remote area, very regional remote area. When the patients are sitting alone, we need somebody to sit with the patient to explain what the doctors are telling. And IT support, very important, because especially in very remote area, there are times there will be low internet access, or there can be problems with the video. So there will be problems with the audio. We really need IT support, which we really enjoy, but we need more. E-prescription. So that is something which I think that is something very important in this remote and telehealth practice, because rather than sending the script over to or faxing or emailing, and I'm sure that this is very well accepted in this country now. When you come to the e-prescription, I can send the script or anything anywhere, or the patient will get a mobile response about the script, and they can show it, or it can go to the chemist. Medical records on one platform. So this is something which is I finding extremely difficult in the practice here, because I need to look into different. I had to open different apps. For example, I need to open the area for the patient notes. I need to open for the CAP for the patient details, pathology reports sometimes, PACS for the X-rays, CTs, PET scans. So we need to merge this thing completely in one platform. And I think the work is going on. And finally, the most important, my interest is to help the geriatric oncology patients. How can we support elderly people in the community? And also the most important thing, the indigenous people, and how to move forward, how to support, whether they have difficulty in hearing, they have difficulty in accessing, they have difficulty in logging in. So these are my challenges, which I see for the last 13 years. Thank you so much.
Thank you very much, Mathew. And I'll now introduce the other members of our panel and begin to bring them into the conversation. I think you'll all agree that it's incredible to see what's been possible in Tamworth and Moree, and be excited to hear some other perspectives. So by way of introduction for the panel, we have joining us Dr. Israfil Baluwala, who's a haematologist based in Newcastle, who has also clinics in Tamworth, and he sees roughly 50 patients over 2 days when he's in Tamworth. We also have Jennifer Hamilton, who's the clinical nurse consultant at Moree that Mathew referred to, and she works in the clinical and educational positions in these roles, and has a passion for the optimal health outcomes for all rural patients. But she's worked in oncology for the past 11 years and has been successfully using telehealth with Dr. George to offer chemotherapy and follow-up. And we have also Dr. Craig Underhill, who you might remember from one of our cancer conversations last year. Craig's the Director of Cancer Services at Albury-Wodonga Regional Cancer Centre and Clinical Director of the Hume Regional Integrated Cancer Service and Regional Oncology Lead for the Victorian Comprehensive Cancer Centre. And he's got conjoined appointments with the University of New South Wales, and is a professor at Charles Sturt. Matt and Craig's here tonight because he's also a major advocate for clinical trials using the new teletrials model. So welcome to all of our panel. And if I could I noticed a couple of people have put questions in the chat. Could you pop them into the Q&A function so that I can see them and they don't get confused with certificates of attendance? So Israfil, I'm going to start with you. One of the things I think when we were first talking about telehealth was that really sick patients it wouldn't work for, and our haematology patients are some of the sickest that you can see. And I just really wonder if there are particular challenges that you see for haematology and how you manage that in a telehealth environment.
Yeah, I do see around, let's say, 50 patients every fortnight with telehealth from Newcastle, because I was at Tamworth every fortnight. So a week when I'm in Newcastle, I see patients. Now, yeah, so telehealth kind of has improved a lot because I cover a lot of Hunter, New England, right up to Tenterfield at the moment. There's a new hematologist at Aranda, so that might get a little bit better. But yeah, Tenterfield, Moree, Narrabri, so it's quite a big area. And it has made things easier because, some patients you need to see them quickly, and they would just refuse to come down. It's a decent travel to the biggest regional center is Tamworth, which would still be 3 to 4 hours away to get the patient in. And like telehealth has opened up, it's made it possible for us to see them, quickly. And then I can make a decision if they're too sick, whether to bring them down to Newcastle or to get them to Tamworth, and, whichever is appropriate, depending how sick they are. And it has worked out quite good. Patients prefer it. I've got a few younger ones who use telehealth from home, and they prefer it. I've got a couple of residential patients who are living in residential homes, and because I need to see them every month to watch their numbers, with myeloma patients on immunosuppression. And so, otherwise they wouldn't have come down otherwise. If it was only a face-to-face, they would have refused. It's just too much of traveling. And so it is possible now to treat patients just by telehealth, which wasn't possible by face-to-face. As Mathew said, yes, occasionally GPs would join in the conversation, which would make it much easier if there's any complicated patients. I still find it a little hard with complicated discussions. So like, if you're starting treatment, or let's say progressive disease, or, you're saying you need to stop treatment, those discussions are still quite hard on a telehealth. You still find an invisible wall, which patients do find it quite hard. And so for those discussions, I normally bring them face-to-face, if possible. Occasionally, I've had to do telehealth because it's just too far. They refuse to come, or they're too unwell to come down. So, but yeah, so there's limitations to telehealth as good, as with anything. But for me, 80 to 90% of the times I find telehealth quite good. Occasionally, I had to do a 3-way family meeting where the family members is not in the same place as the patient, but you could, so you could do a 3 or 4-way talk, which is quite good in that way, which was previously not possible. The only thing I still find it a way to improve that my virtual care has got a couple of limitations, I guess, is like when you're using Zoom, you could open up a new window and you could share, let's say I wanted to show them a PET scan pictures, which by my virtual care, you can't really do that. And that's one thing I kind of find, if someone's across, and you want to show them the PET scan, pictures, you can't do that. So that's one thing I would like to improve. And yeah, e-prescriptions would be good. The other thing would be e-orders. I still find it hard because because our patient is spread so wide, everyone goes to their own radiology center, and then you have to have this multiple logins to access different CT scans, and to compare them. Yeah, it does get very hard and complicated.
And those are some of the things that perhaps the system could embrace, aren't they? The things like the common platforms, which would be...
That's right.
Should be technologically possible.
It is, and I think partly because I guess each LHD has its own way of doing things. Things might change in the future, I guess, with New South Wales implementing a single patient digital record. So that might change in the next 3-4 years. Yeah, but I guess the other thing is, which I've noticed is, which the whole platform gets limited, is the internet connectivity. Because the further you go rural, the internet connection is not great. And then your patients often complain of voice breaking up, it's not, and I still have around 10% of patients who refuse to do telehealth. They will travel 3 hours just to see me for 10 minutes because they find it much better to talk to me face to face.
Yep. And Jennifer, I might throw to you, because one of the things that we talked about before was that one of the reasons the patients come into the treatment centre to do the telehealth from Moree to Tamworth is because of one of the reasons is the technology, both access to the platform but also bandwidth. Can you talk just a little bit about your role and the sorts of ways in which your role supports the patients to really access telehealth as an enabler?
So Mainly particularly our Indigenous population and our older population, Moree, we don't have fantastic internet connection, and a lot of people don't have access to be able to do it at home, but they also need somebody to be there to explain what's happening with the telehealth. So when Dr. George is talking to them from Tamworth, they might need a little bit of clarification around what happens or what happens next, where the appointments get made and how that happens. But the younger people obviously are much better at it and are quite happy to, just log on and log off. But our Indigenous population and our elderly population, which we have a lot of in our clinic, they're the ones that don't particularly want to travel, but they need more help to do the telehealth, and so they come into our unit.
And how has the availability of telehealth changed their experiences then?
Well, it's so much easier. I mean, a lot of them can't travel themselves, so they need, they need a family member to take them. They need, or they need to get patient transport. Transport is our biggest issue in rural areas to get to, because these people are travelling to see the doctor. They're travelling to have a couple of different tests in different places. Our closest PET scan is Newcastle or Toowoomba, which are both 5 hours away. Then they would have to travel back to the doctor to get the results of that. Then they would have to travel for their treatment. So it's cut a lot of travelling out for the patients, and it's very successful.
Fantastic. Thanks. So Craig, over to you. Tell us a little bit about what teletrials are and how that's different to, or the same or different to telehealth generally, and what that's enabling for rural patients.
And thanks, Sanchia, for asking me along tonight. So the short answer is it's not really any different. So just like we've seen this great uptake in telehealth during the pandemic and using it for consultations or for having a quick look at a patient to screen them, see whether they need to come in, or giving a quick opinion, as Mathew talked about, it's just really the same processes to run a trial. So it's not it's not going to replace all of the face-to-face visits, but it does have a place to decentralized trials. So the North Americans, Canadians and US, they use the term decentralized clinical trials. So really taking a much more patient-centered approach, doing tasks in their remote place that doesn't require a visit at the big centre. Could be a blood test, could be an X-ray, could be a screening consultation to see whether they're eligible for trial, could be a day 7 visit where you just want the nurse to take their vital signs and eyeball them and see that they're okay. So it's a tool to help the conduct of trials, and we see, on regularly patients in rural and remote Australia, regional Australia, declining the opportunity to go onto a trial because there's a requirement that they have to travel to a capital city to access that drug. So it's a way to try and bring virtual trials to the patient.
Fantastic. And when we had a conversation the other day, we talked about the fact that actually it's not so much the clinical pieces that are harder to put in place. It's been working through all the kind of compliance and regulatory pieces. Can you talk a little bit about those kind of barriers and the evolution that you're seeing in acceptance of teletrials?
Yeah, so the regulators accepting it, the farmers accepting it, all those, there's sort of a heterogeneous, not sure the word, view of that from farmers. So I think once they've had some experience, like anything, they're much more comfortable. So COSA has published a framework nationally, and each jurisdiction is now really streamlining that regulation, harmonising it. So Moree and Moree put a question there in the Q&A. How are you managing drug transport for clinical trials? That's a common question. So Medicines Australia has a policy. The drug should be shipped to a oncology pharmacy that can store the drug, account for its administration. That log can be then monitored remotely by the contract research organisation. So there's processes in place, but it's really about shipping the drug to a registered oncology pharmacy that undergoes the same kind of regulatory processes that it would anywhere.
Fantastic. So I'm going to go to the questions because this has opened up some rather than I've got a list of my own, but let's see. So one of the questions from Cassie Abbott is, do you find your clinical assessment may not be as thorough due to it being via telehealth, for example, not being able to assess the lungs and the heart? And this might also be an opportunity perhaps for a conversation to bring in what the role of the GP might be as well as the nurse. So I might ask you, Mathew, and then Israfil to comment on that one. Sorry, still on mute, Mathew, sorry.
So cancer patients are slightly different to what we see in general practice. There are two types of patients. One is new patients and review patients. The new patients are either the patients who are on chemotherapy or the patients who had a lot of imagings done. So previously there are scan or PET scans or anything done. So majority of the patients, I don't think that a clear physical examination is needed all the time, but we rely more on imaging at the moment, because that's where the cancer treatment goes. But there are times when that clinical examination is needed, which I mentioned some time ago, about the virtual care, and we ask the patient go straight to the emergency department. Or there are times in my practice, I ask the nurse there, can you please turn around the patient and have a look? I can have a look at it. I can't do the physical examination, but I can do some physical, I can see the patient, but definitely there is a lesser role of physical examination for a oncology practice, because we rely more on the imaging and blood parameters, and I agree with the hematology doctors too.
Okay. Israfil, have you got a comment on that one?
Yeah, I agree with Mathew. I guess once we have a lot of imaging, we rely on a lot of images to assess disease status and what's happening, and sometimes the role of actual physical examination is a bit lesser. Of course, as if it looks like I need to see them physically, sometimes I do book them again and bring them down for a face-to-face appointment. I guess if you're worried about relapse or any side effects of chemo, then yes, sometimes we have to rely, we order like echocardiograms to look at the heart, or CTs or PET scans. So the role of physical examination has got less and less with the more imaging available to assess things. So yeah. But yeah, again, sometimes when physical is needed or face-to-face appointment, we just have to bring them down.
Terrific. Craig, I'll let you make a comment to that, but also maybe start on a question from Charmaine Chilton, who's asked around whether the consults are mostly for people on oral chemotherapy or whether there's others involved as well.
Yeah, so I agree with what the first two speakers have just said about the physical exam. So there's a place for getting the patient in, but sometimes you don't need to. And I looked down my list of review patients for this afternoon in the morning session. I thought, oh, look, there's a couple of people here who've just had their scans for their 6 monthly reviews. I don't really need them to drive an hour and a half one way to see me. I might, we actually offered to convert a couple of people over to telehealth appointments. So it's about incorporating what's right. And sometimes you do that call and think, oh, I actually do need to get you to come in and still see me on another day to be examined. There's actually some guidelines published in Oncology last year by a group in Victoria, including myself. So we actually did some guidelines on the appropriate use of telehealth in oncology. And there's actually a table in there that goes through sort of tumour by tumour, what some suggestions on what might be appropriate to use telehealth or not. And overlying that's always the patient's preference. Sometimes they want to still come in and see you. So look, teletrials are not just about intravenous or oral, it can be either. So, and there's a question I think about, are there clinics, remote clinics involved with delivering chemo remotely? And yes, there are in Queensland, and as Mathew said, and we've had experience locally as well, where you can do a screening call the day before or on the day of the chemo, and the patient can then have the chemotherapy, appropriately credentialed with trained staff in a remote town. So the patient, doesn't have to always come into the big centre.
And then there was a related question about whether the GP's in the delegation log for some of the parts of the protocol.
Yes, you can do that. It is possible to do that. So, or it could be just, chemotherapy nurse in the remote town, if the requirement's just really to take their vital signs and assist with the call. Again, that can be delegated and accounted for as part of the trial documentation.
Terrific. Jenny, one of the things is that you're out in Moree without Mathew and Israfil there every day. And so do you have a liaison role with general practice, or is there really an issue with even availability of general practice in regional and remote communities, and therefore the oncologist kind of takes on more? How do you see that playing out in the clinical environment?
There's definitely a shortage of general practitioners in the rural areas. But in saying that, being also a small country town and the rural areas, the GPs have a very close association with their patients with cancer. And so we tend to be able to have a direct access to them. We probably all rely on each other more, like the GP will, if they are seeing the patient or if they're doing a telephone consult, they might send the patient down to us. So, and then we can assess them. We can then decide, do we think it's an oncology thing, or do we think it's more of a general practitioner thing? And then, for example, if it's a pre-treatment thing, or if it's a side effect or toxicity, we then contact Mathew, and he does a My Virtual Care. So then,
a lot of triage.
So yes, a lot of triage, and then he then decides, is it something that the GP can handle? If it's an emergency type of thing, we take them around to the emergency department. But we also, our unit gets used a lot as a triage centre. The patients tend to come to us because we're trying to keep them out of the emergency department. So sometimes they can, they come to us and we can assess them, and then we have access to we send them to the GP to try and keep them out of the emergency department as well.
Great. Now, one of the questions that came in before tonight from people who were planning to be online was around how you promote virtual care models, particularly with decision makers in local health districts. And I think in Craig, in your context, it's actually public-private partnerships across your facility and across 2 states. So you're having to liaise with 2 governments. So I'd be interested if anybody would like to make some comments about really how you've got this started and what it takes to get a local health district and the decision makers on board. Mathew, do you want to take that first?
I leave it to Craig.
Oh, okay. Oh, he's the good decision getter.
Well, look, the pandemic was a real driver, right? So the need to convert from face-to-face consultations in outpatient clinics to telehealth. So that was a real driver. And so I think there was a lot of jurisdictions spent some time training staff and implementing systems like that virtual care that Mathew talked about. In other states, they have different names for the software. I think now I'm not sure what the driver will be, and one of my concerns is with the reduction in the telehealth item numbers, that there might be a move by the bean counters to switch away from the telehealth and trying to say, look, you actually need to get people into the clinic. But if they take a patient-centered view, as Mathew alluded to. There's so many benefits overall to the system. There's benefits to the patient, but there's also benefits from a cost effectiveness and cost to the economy, with reduction in the cost of travel, etc., and just making the care accessible. So, Mathew gave those great examples of patients in remote towns that probably would have just said, no, I'm not going to go and access care in Armidale or Tamworth, who have now been enabled to receive care. One of the difficulties about the telehealth process is, there's a disadvantage. In some ways, it accentuates as disadvantage. If you don't have a smartphone or a computer with a camera, it's harder to access those calls. That's where the primary care centres or community care centres come into play, so the patient can go, and sit in front of a computer or a phone in the GP's practice or community care centre. So we still have to be mindful of that. But
and that's quite a decent infrastructure investment, isn't it? Really,
yeah.
To even have those facilities for people to go to. I'm interested in, as part of that question, Mathew, you're an early adopter. As I mentioned, you got one of the first Cancer Institute grants when I was there, and I think in that call we only had 2 applications, and most people were really sceptical. So how have you recruited your colleagues into doing telehealth, and in oncology and in other sort of areas? Have you become a role model for others to take it up?
To me?
Yes, you.
Right. So it's and talk about the nurses first, because I told and re-emphasize that nursing staff is the backbone for executing this telehealth model. Without a nurse or a team of people in the other end, this is not possible. All the credit goes to Jenny and the team and in Moree, because it is their hard work and their commitment to the community. And if I am the profession, the clinician alone is not sufficient here to run this show. And I can see that the commitment is a group of people there, and the chemo unit, the admin staff, the Jenny, the social worker, and the Indigenous community. We have an excellent connection with the Indigenous community and the work that we have done. And in the beginning, I want to tell you, there are people who are not willing to come to the clinic. I told you there was the number of patients was 8. Now it is around 180, 200 patients clinic. It's a huge clinic going on. And they were reluctant to come from the Indigenous community, but they understood that caring a group of people with the help of virtual care, telehealth, and the support system, that is the backbone. You cannot run a clinic, you cannot run an oncology clinic without a team in the rural area. Absolutely impossible. And even if you talk about the teletrial, if you talk about any project in that matter. So definitely, I would say, answering to that question, getting the right people in the team, and the same commitment, same vision is the most important thing.
And Jenny, I'll get you to follow up on that. So there's a question from an anonymous person who's asked around the fact of, are there even enough skilled nursing resources in rural, with the shortage in the rural workforce? But one of the things that Sabason, who I think we can call the father of tele-oncology in Australia, I think most people would agree with that. He talks about the fact that the telehealth work that they've been doing out of Townsville has really helped to cement workforce in rural environments, because it improves work satisfaction and kind of career development. So Jennifer, I'd really be interested in your views on what it's meant to be a nurse in this environment, and how your colleagues maybe see it as well.
We've got a really good group of people. We're all very well trained. So the four of us are all emergency department trained. We're all actually local born and bred Moree people. So we've been working at the hospital and working together for more than 30 years. So we know each other, we know how we work, we know the community and the people that work there. But telehealth has just made it so much easier and so much better to promote the service, because our patients come in and we're assessing them, and so the computer sits at their bedside and we dial in. We send Mathew a text and he dials in, and the patient he's there to back us up within 5 minutes if we need to, and the next person that if he's in the middle of a clinic. So we've got immediate access, even though Mathew is 300 k's away, we've got direct access to him all the time. So we don't feel like we're there doing it on our own. So I think, that helps. With opening the Narrabri unit, it's very new. We did have a bit of trouble getting some staff, so we've now fulfilled the positions. They had no oncology experience, so the telehealth has helped with that too, because I dial into the My Virtual Care platform at any time when the girls need me to support them, because they're 100 kilometres away, so I can't be there in both places at once. So they log into the My Virtual Care, them and I, if the patient's involved. If not, we use Skype. So we, the technology brings us all together, so we can, even though we're extending to Narrabri, we're still all one unit that work together, and it works really well.
Fantastic. And I think you're obviously seeing a skill set develop that didn't exist there before, which will help to build the community. So, Craig, you've said you'd like to answer the other question from anonymous attendee. For the centres that are about to or not yet ventured into video or telehealth, do you have any words of advice?
Oh, yeah, sure. Can I just follow up from Jenny's comment?
Sure,
the GPs also love it when you bring them into the telehealth course. If you do one with the GP, the feedback from the GPs we've involved like that in remote towns is they feel really part of the network, and it upskills them into sort of the questions to ask and management of side effects of chemotherapy and immunotherapy. But yes, so the words of advice.
And do you have to use two different platforms for your Victorian versus your New South Wales patients? How does that work? Same platform?
No, we can send them a link to our platform and they can dial into that, or I think they're all the same thing, but they're called different names in different jurisdictions. But my advice would be to go to the resources for people who haven't been involved. So again, I noticed on the New South Wales Health website, there's lots of resources of how to set up telehealth and using that virtual care system. For teletrials, there's a COSA framework. There's also the Victorian Comprehensive Cancer Centre Alliance has published a toolkit and some training modules. They're also being updated and enhanced for national use. So there's lots of resources around that people can utilise. It's not, you don't have to reinvent the wheel. It's not a blank sheet.
And Israfil, is there anything like that specifically for haematology, or these have kind of all been done together? Is there special advice you'd like to give?
No, I think it's the same, I guess, with onco or haematology, with telehealth. It is resource intensive, so you need a good team support to set it up. But I guess, once with telehealth bookings now, yes, some patients prefer at home. Before they had to go to their local community centers or GPs, then you need admin staff to book things, and then you need GP centers to make sure they are, up to date with the software to provide that service. So yeah, it does need a bit of resource, but once it's set up, then I think it works well.
Fantastic. Okay, so in the few minutes that we've got left, I'm going to invite you each to give some closing remarks for a minute about other messages that we haven't managed to talk about tonight. So I'll start where we began, Mathew, with you.
Thank you for inviting me to share my experience. And I would say the major part of my life is in this regional and rural area, and I will die here. And so this is the experience I got, and I'm so happy when I see patients in a regional and remote area who are coming with a good outcome and their happiness, the smiley faces. That makes me to do more and more, and opening more clinics. And sometimes nursing staff finding it hard, but that drives me to do more things in my life. And then it's really transformed thousands of people in this remote area. And I think the telehealth should continue, and the people should support, and GP should be part of it. And we need more involvement of the GP and the community, so that, and more innovations are needed so that people will enjoy this service.
Israfil?
Yeah, telehealth has opened more opportunities for us, for patients in rural areas to access, medical care. Of course, yes, if we can improve the service to deliver better care, like, with prescription, e-orders, better imaging services and technology, that would be great. But yeah, like I work in Newcastle, so I work in Newcastle's still called regional, but it's the second largest city after Sydney, and then Tamworth. So it's a bit of quite experience, and patients do appreciate a lot, especially in the rural areas, of whatever services they're getting. And I think, we should make all efforts to keep providing that service and improve on them.
Thanks. Jennifer?
The only thing I can say is that it's easy to learn how to do, even for the technologically challenged people. It's not something that was hard to set up. The biggest thing, I guess, moving forward that we will need in the regional areas is better IT access, so better internet coverage, and that would make it even better for the patients. But no, it's very good, and it's something that I think we need to use more of, because as people don't have the ability or the family members to travel to the largest centres, it is just so much easier for them to access care. So it does make it more patient-centred.
Thanks, Jennifer. And Craig?
Well, I think we've seen tonight, the great benefits. There's still some barriers to overcome that we're all working on. Telehealth's here to stay. Teletrial methodology is here to stay. If you're doing your telehealth consultation, you can also bring that into use in trials. We shouldn't forget about support for telehealth consultation. So there was a raft of item numbers brought into play during the pandemic. They've been reduced. There's a lot of advocacy going on nationally about extending those, enhancing them. I think, we should not forget about that advocacy role that we all have to support this kind of system.
Thanks. And I think just to, I guess, from me in closing, that if we think about the fact that rural and remote patients have about a 5 percentage points worse outcomes than their city cousins, and if you add to that the greater poverty in the regions where, if you're in the lowest socioeconomic group, you're 37% more likely to die of cancer than if you're in the highest socioeconomic group across most of the cancers. I think that what we need to do is thank all of you for your commitment to improving outcomes for people in rural and remote communities, both the ones that you live in, but also the ones you reach out to. And so in closing, I'd really just like to thank you for your contribution tonight, but also in your professional lives, because I think it is, as a country girl from rural New Zealand, it's a very important thing that you're doing, and we really appreciate you being here tonight. Just a reminder to email to the email address in the chat if you'd like a certificate of attendance, and we'll see you at the next Cancer Conversation. Thanks so much for being here tonight.
Thank you.
Thank you.
Thanks for having us.
That's okay. Bye.